finger close to face in the left eye, and there was a RAPD grade 2. There were no scratch marks, macule, papule suggestive of any cat scratch marks on the skin of the child. On examination, there was a grade 5 disc edema with complete obscuration of vessels, dilatation and tortuosity of peripapillary vessels, and macular exudates forming a complete star at the macula, and rest of the retina was normal. On line scan of the disc, there was a disc edema, and on line scan of the macula, we can see that there is overlying vitritis. There is a seeping of the SRF and exudates into the peripapillary retina. On doing the ultrasound B scan, there was an elevation of the disc with overlying vitritis, and there was a retinochoroidal thickening in the left eye. We did a complete blood panel for the test, whatever was available in our resource poor setting. So the complete blood count, differential count, and peripheral blood smear was within normal limits. It was not suggestive of any ALL or lymphoma. CRP was 3. We did a infectious panel. MON2 and quantiferon TB was negative, and serology was negative for herpes simplex, cryptococcal antigen, typhoid, dengue, syphilis, and the child was immunocompetent. There was no HIV, hepatitis B, or hepatitis C. Urine culture, blood culture showed no growth. We did an autoimmune panel. Serum AC was 46 units per ml, which is normal for a normal range for a child. Serum lysozyme, ANA, and RA factor were within normal limits, and the metabolic profile was also within normal limits. So by now we were suspecting a atypical optic neuritis. We ordered an MRI brain and orbit. There was a hyperintensity and thickening of the optic nerve on the left side. In the brain, there were no hyperintensity suggestive of any infection or inflammation. The CCT chest was normal, not suggestive of any old or recent TB infection or sarcoidosis. And so most common cause means the most common thing which can be there in such a setting is it can either be idiopathic or it can be due to Bartonella. So in Bartonella, mostly we see a lymphadenopathy. But we did an ultrasound neck, there was no significant cervical lymphadenopathy, and we wanted to start IVMP for this patient. So we did an ultrasound abdomen to rule out abdominal TB. It was negative. So our diagnosis, which we were suspecting, was isolated neuroretinitis, which could be idiopathic or due to Bartonella, since there was a history of occasional contact with kittens. Now mostly these neuroretinitis cases can improve on their own, but since there is a severe disc edema and there was a profound loss of vision, so we thought that we should give an IVMP and cover it with antibiotics. So we gave an IVMP 15 milligram per kg per day for 5 days for this child, which was followed by a slow tapering with oral steroid, and we gave a 10 milligram per kg IV 3 days of azithromycin, which was followed by oral azithromycin. The better treatment for a Bartonella could have been doxycycline, but since the child was 13-year-old and he was already looking stunted, so I didn't want to start doxycycline. I started with the second line, which was azithromycin. So after the IVMP, the vision after the first dose was 3/60, and it improved dramatically over time, and off the steroids and off the antibiotics 1 month, the BCVA was 6.69 BCVA, and there was still RAPD grade 1. The disc picture had improved much. There was a fibrous consolidation at the disc. There was a formation of ERM, and there is a disruption at the fovea and ISOS junction. Rest the vision is still, even after 3 months, it is 6/6 partial. So mostly the neuroretinitis is idiopathic, and the diagnosis can be made after ruling out the causes, which can be most common Bartonella or TB, toxosyphilis, Lyme, leptospira, or the viruses, or it can be due to sarcoidosis. Thank you. Switch.
Hi, hello, good morning everyone. Today I am reporting a case on prompt diagnosis and management of a case of VKH. VKH is a multi-system T-cell mediated autoimmune disorder targeting melanocytes. It's more common in pigmented population. Prevalence in India is 21% of the cases of panuveitis. So it has ocular features, integumentary features, auditory features, and neurological features. It is mainly diagnosis is based on OCT, FFA, and ICGA. Prompt high dose steroids with early immunomodulators is the treatment of choice. So my case is a case of 23-year-old female who presented to emergency department with a complaint of blurred vision in both eye and headache. She experienced sudden onset and progressively worsening vision in right eye over past 1 week, and similar features in left eye also for last 2 days, associated with mild pain and redness in both eyes. On ocular examination, visual acuity was finger count at 4 meter and 3 meter in right eye and left eye respectively, decreased contrast sensitivity and color vision. Intraocular pressure was normal, pupillary reaction was brisk, and no RAPD was noted. On assessment of anterior segment on slit lamp examination, mild congestion was noted, cornea was clear, AC was quiet, no cells in vitreous phase. On evaluation of the posterior segment on first day, there was bilateral exudative RD was noted and papilledema was noted. On OCT evaluation, subretinal fluid was noted with septal formation, exudative RD in both eyes, and RP undulations. On FFA, multiple pinpoint hyperfluorescence was noted, optic disc hyperfluorescence, and late phase leakage. So we investigated the patient thoroughly, and only ESR and CRP were raised. Rest investigations were within normal limits. So we need to exclude the close mimics for this case. As there was no history of trauma or any intraocular surgery, so we ruled out sympathetic ophthalmia. As the serology screening was normal, so we ruled out infectious uveitis. On USGB scan, there was no signs, or no T sign or any sign of scleral edema, so we ruled out posterior scleritis. The other mimicker is intraocular lymphoma or masquerade syndrome, but the presentation is usually in older age group and usually painless, so that's also ruled out. And on serology, there was normal angiotensin converting enzyme, serolysozyme, and chest X-ray, so sarcoidosis was out of picture. So we diagnosed the case as probable VKH in acute uveitic phase. So patient was started immediately on IV dexamethasone for 3 days and then switched to oral prednisolone 1 mg per kg per day for next 2 weeks. After 2 weeks, we reassessed the patient and started her on oral azathioprine. Then continued both steroids and azathioprine. Slow tapering of oral steroids was done, always under OCT guidance. Azathioprine was maintained dose for longer duration. Withdrawal is only after 12 to 18 months of quiescence phase. We continued monitoring with OCT scans and CBC and LFT for azathioprine. This is day 3 picture when we started the patient on treatment. Visual acuity was 660 and finger count 6 meter with decreased contrast sensitivity and color vision with bilateral exudative RD. As you can see in OCT scans also. This is 1 week follow-up where visual acuity drastically improved to 624, 636. Contrast and color vision also improved. And on OCT scans, you can see the fluid level decreased. This is second week follow-up. Again, vision improved and the fluid level decreased. So we started the patient on azathioprine second week onwards. This is week 3 follow-up, 1 month follow-up, and then we started tapering the dose of steroids. As we can see, there's no fluid at all, so we decreased the dose. This is 3 month follow-up. Patient achieved 6.6 in both eyes with a normal contrast sensitivity and color vision. This is 6 month follow-up where we can see the patient has still maintained 6.6 in both eye and normal contrast and color vision. There's no fluid at all and only photoreceptor changes at ISOS junction. So what's unique about this case? Ocular only symptoms, that means probable VKH, are the cases which are underdiagnosed and underreported. Only 1.4 to 3% of total VKH cases. Early diagnosis with multimodal imaging is important. Early and aggressive dual therapy results into excellent visual recovery. No chronic sequelae on long-term follow-up if we start on treatment early. So what we need to keep in mind is probable VKH are the cases which has only ocular changes. What is the diagnostic criteria? Bilateral exudative RD, increased choroidal thickness, and multiple pinpoint leaks on FA. We should always exclude infections, mainly TB and syphilis, before starting the patient on treatment, that is steroids. Use OCT scans to monitor the treatment response. Always slowly taper steroids. Never stop abruptly. Relapse risk is very high. So the take-home message is: do not wait for systemic signs. Recognize early and treat ocular VKH as early as possible. Thank you.
Good morning. Myself, Dr. Murkrishna. Today I'm going to present with a persistent diagnostic challenge managing an evolving case of optic neuritis. So, aim to report a fascinating case of unilateral optic neuritis in a young male that continues to pose diagnostic dilemmas, showcase the complexities in its diagnosis. Analyzing differential diagnosis of optic neuritis, highlighting the need to distinguish demyelinating, autoimmune, infectious, ischemic, and nutritional causes for accurate diagnosis and treatment. So here comes a 18-year-old male with a complaints of a sudden onset unilateral domination in left eye for past 4 days after awakening up in the morning. So systemic and past history was not significant. Family history was not significant. Personal history was he was a vegetarian by diet. So on ocular examination, right eye was examination points were within normal limit. In the left eye, visual activity showed 6/24 with pinhole not improving. Color vision was defective. Contrast sensitivity was defective, and extraocular late agnexa conjunctiva was within normal limit. So cornea anterior chamber was within normal. People showed left eye RAPD grade 2. Lens was clear. So on fundus examination, right eye showed within normal limit, and the left eye showed blurring of optic disc nasal margin with a hemorrhage spot on nasal to the optic disc. Macula and rest fundus was within normal limit. So perimetry showed right eye within normal limits, and the left eye inferior alternate defect was seen. So in fundus fluorescence, it showed the right eye retinal circulation within normal in right eye, and whereas in the left eye, it showed disc leakage in the late phase. So the MRI brain orbit 2 mm optic nerve showed bulky retrobulbar and intraorbital segment of left optic nerve with still hyperintense signal and mild enhancement suggestive of left optic neuritis. VEP showed right eye with normal P10 latency, and left eye showed increased P100 latency. So for this patient, multidisciplinary approach was made, and the neurological consultation made. All investigation like CSF, lumbar puncture was done, include AFB fasting and CBNAT, Indian fluid cytology, KOH culture was negative. Systemic infection and autoimmune workup was done, like ANA, ANCA, VDR was negative. All tests was negative, including serum and MOG antibody test was negative. So what we found is in this patient, oligoclonal bands was absent in both in serum as well as CSF, and low serum B12 levels were seen. Increased serum immunoglobulin levels more than 2100. So here comes the differential diagnosis. So demyelinating optic neuritis, MS-related optic neuritis was, whatever the points in favor was. He was a young patient, and the MRI showed hyperintensity with enhancement, and VP showed a delayed P100. So points was against was oligoclonal bands were negative in serum as well as CSF. Alternate defect was no ischemic and no MS brain, multiple sclerosis brain lesions was there, no pain and ointment. So it would be the most probable list. So next comes to the neuromyelitis optic spectrum disorder. So points was favor was severe optic neuritis was possible, raised immunoglobulin versus. So the points were against was it was only unilateral, no myelitis or systemic features, and aquaporin tunnels were negative. So it could be possible. So MOG antibody associated optic neuritis was point was famous disc swelling with hemorrhage, bulky optic neuritis on MRI. So typical approach is same. Point was against like antibodies were negative, and it is usually bilateral. So probable maybe. So ischemic optic neuropathy, point was favors the altitude defect was seen. Disc blurring with hemorrhage was seen. So against was like MRI showed enhancement and VAP showed latency. In AON, the amplitude will be decreased and latency will be normal and less likely diagnosis. Infectious optic neuritis like TB, syphilis, HSV, Lyme, Bartonella. Pine was famous like it can mimic optic neuritis and discriminant was also present, raised immunoglobulin was also present. But against was has no systemic features or MRI and MRI was showing demyelinating features. So less likely to be normal. Our nutritional and toxic optic neuropathy like he was a vegetarian by diet, so low serum B12 was seen possible. It could be a B12 deficiency toxins, but typically, this vitamin B12 shows bilateral symmetric, so unlikely to be diagnosis. So on further course, this patient was planned to start intravenous methylprednisolone. So, but on second day of admission, spontaneous improved vision was noted. With resolution of fundus changes, patient was kept on follow-up and given vitamin B12 injections. At first month follow-up, visual activated 6/6 pustules with a mild red saturation. So discussion, this case of unilateral optic neuritis with acute vision loss, optic disc blurring and inferior alternate defect was diagnostic challenge due to overlapping features with various optic neuropathies. MRI confirmed left optic neuritis and VEP showed increased P under latency, while elevated serum hemoglobin is result of underlying autoimmune process. Differentiating demyelinating like multiple sclerosis and NMOSD, MOG optic neuritis, autoimmune, ischemic and nutritional causes was crucial to guide treatment. And a structured stepwise diagnostic approach integrating clinical imaging laboratory findings is essential for accurate diagnosis and optimal management. So here comes the conclusion. This case highlights complexity of diagnosis of optic neuritis and the need for a thorough multidisciplinary discipline approach to understand its diversity in etiology and facilitating a more effective management strategies. Accurately diagnosing optic neuritis requires distinction between demyelinating, autoimmune, ischemic, infectious, and nutrial causes, crucial to prevent mismanaged and optimal outcomes. These are my references. Thank you.
Okay, good morning everyone. So I'm here to present a case, actually a story of a hare and a turtle. So a 52-year-old female walks into the OPD with diminution of vision in the left eye since 3 days. History of trivial trauma to the left eye 20 days ago, which was not significant. On examination, her visual acuity in the right eye was 6's, in the left eye was 6/18 with no improvement with pinhole. Pupil had RRR in the right eye, and in the left eye there was grade 1 RAPD. Color vision had no defect when it comes to the right eye, and when in the left eye it had red-green defect. Contrast was normal in both eyes, and posterior segment evaluation was normal in both eyes. So these are the clinical picture of the patient. Her versions were normal on the outset, but when we look at the horizontal movement of her eyes, here we can see that the left eye had a lag when it came to the lateral movement, whereas the right eye medial rectus was moving in a very good manner. So the hare in this case is the right eye medial rectus, and the turtle, which is slower, is the left eye lateral rectus. So there was a lag in this movement in the yoke muscles. So we got an MRI done, and it said that there was a lateral rectus enlargement at its belly and not in the tendon. So it was compressing the optic nerve at the orbital apex, and the lacrimal gland in the left eye was enlarged and was hyperintense on T2. All the blood tests that we did, the chest X-ray, first line, second line for the autoimmune diseases also was negative. So we didn't find anything positive in that. So let's come to the course. Oral steroids were started, 1 mg per kg, and the patient was symptomatically better. She was sent home. After 2 months, the patient's symptoms recurred. But this time around, the color vision was normal. So we got a new information that she was on Ayurvedic medication 6 months, from 6 months, but that was not again significant. Her lag in the left lateral rectus was still present. We got a repeat MRI done, and there was only decrease in the size of the lateral rectus, but the lacrimal gland enlargement remained. So she was admitted, IVMP was given for 3 days, her vision came back to 6/6. and the color vision again was had no defect, and that lag that she had in the initial presentation was absent now. So, working diagnosis of left eye non-specific orbital inflammatory disease was made. At this point, what more could have been done? A biopsy could have been taken, a full body CT could have been done, and IgG4 should have been done. So 1 year passed by, the patient never came back, and then again she comes back with the same complaint, but this time with full-blown redness, proptosis, and everything, which suggests lid edema, which suggests inflammation of the orbit. So what next? We did serum IgG4 because the lacrimal gland was still inflamed. It was negative. So what is unique about this case that it is one of the very few, actually the only NSOID that I could find on the internet which has a presenting complaint as a diminution of vision, because all the others either have pain, redness, proptosis, lid edema, pain on movements or restricted movements. No one ever came with diminution of vision. So what's the take-home message? So inflammatory signs need not be the first symptoms, as in this case it came after an year. 1/4 of the cases are refractory, so once a patient can always come back. Time of starting of steroids depends on the case. It's very particular. There is no fixed regime for that. Thank you.
नहीं नहीं डाल दें. So, good morning everyone. Let's start with the storytelling presentation on carotid cavernous fistula. So my patient, 20 years old male, resident of Ghaziabad, Hindu by religion, came to me with complaints that doctor, my left eye became red and bulging and I can even hear a sound inside my head. The exact timeline of events were 4 months ago it was an RTA, 3 weeks later it was followed by left eye redness and progressive protrusion. 2 weeks after, patient feels the eye is throbbing like a heartbeat, and presently there was severe headache with decreased vision. The detective clues in our inspection were 6/60 visual acuity in left eye and abaxial proptosis of the left eye. on the visible pulsations over swelling were present. Play नहीं होगा क्या? Video play करनी है. There were visible pulsations over the swelling. Dilated episcleral vessels were present with raised IOP and ophthalmoplegia. On palpation, there was a 4 into 4 mm upper lid soft cystic compressible mass with no resistance on retropulsion, palpable pulsations, and size increasing on valsalva. By Rouleau method, 16 mm was right eye and 21 mm was left eye. On auscultation, bruit was heard over the swelling. Fundus left eye showed hyperemic disc with tortuous blood vessels. On investigations, MRI showed enlarged SOV and MR angiography showed the abnormal arterial venous connection. DSA was done, which is the presently gold standard diagnosis. This is the MRI and this is the MRA. The classical signs which caught our attention was the pulsatile proptosis, the dilated episcleral vessels, and the audible bruit. And the diagnosis which we made was left carotid cavernous fistula of direct type. So the major differences between the direct and the indirect CCFR, direct is usually followed by high flow, post-traumatic and more dramatic. And indirect is low flow, spontaneous with subtle presentation. We referred the patient and the management was done was coil embolization using endovascular technique. The outcome before versus after was, before there was severe proptosis with dilated episcleral vessels and bruit, and after embolization, the proptosis decreased, the bruit disappeared, and the vision improved. This was the post-intervention image. The take-home messages are, always suspect CCF in patients with sudden proptosis and bruit, and ophthalmologists are often the first to detect it. Endovascular therapy offers excellent prognosis. Thank you.
Timer.
Good morning everyone, I am Kaveri and today I will be presenting my 2 bilateral ptosis cases with distinct genetic etiologies. If you see the first slide, the presentation is mostly similar, but the key is not in the looks but the story that shall unfold. My first case is a 5-year-old male who presented with the chief complaints of drooping of both upper eyelids, which was noticed at the age of 1 month. The parents noticed drooping of both upper eyelids, which was symmetrical and varied in extent throughout the day. And they noticed that it improved when the child woke up from sleep, and it was associated with chin lift. There was no history of double vision, no history of trauma, and no history of prior similar episodes. Since the child was admitted in ICU for pneumonia twice, we went ahead with an ENT evaluation and no significant abnormality was found. The child was in full-term normal vaginal institutional delivery born out of a non-consanguineous marriage. The important part was that he had a elder brother with the similar complaints. The best corrected vision was 6/6 in both the eyes, and the head posture, he had a chin lift. Coming to the eyebrows, there was uplifting of the brows indicating a frontalis overaction. There was presence of lid crease. The palpable fissure was 28 into 6 mm with an MRD1 of 1 mm. There was no pigmentary retinopathy and the rest examination was within normal limits. The photo depicts the same. The ocular movements were restricted in all the gazes. Because of a high clinical suspicion, we went ahead with the ice pack test and it was found to be positive. We even went ahead with the Kogan lid twitch test, and if you notice carefully, there's a twitch when he looks upwards. The second test that we did was the curtain sign test. When you see the right lid is elevated, the left lid droops. We went ahead with the blood investigation and we found out that antibodies for acetylcholine receptors were negative. Again, with our strong clinical suspicion, we went ahead with the genetic testing. And we found that the pathogenic variants in the Cherney gene were positive, indicating congenital myasthenic syndrome. And the inheritance pattern is autosomal recessive. We managed the case with PEDS and with tablet pyridostigmine and syrup salbutamol. Salbutamol is the important part here. It is usually seen to benefit patients who have DOX7 mutation, but here also it benefited the child. Our second case, and a more interesting case, is of a 30-year-old female who presented with drooping of both her upper eyelids since birth and inability to move her eyes in any directions, which was noticed at the age of 6 months. Her parents reported the same complaints, and again, since the early school years, the patient has found it difficult to climb stairs. In the past few years, she also noticed that her hand grip is also becoming weaker. There was no history of double vision, no limb pain, no loss of sensation, and the patient is a regular glass wearer. The pedigree was the interesting part, that the patient was born out of a consanguineous marriage to maternally related parents, and all 3 siblings were affected with similar complaints and similar age of onset. On ocular examination, the vision was 612 in both the eyes, and again the patient had a chin lift. The lid crease was absent, the palpebral fissure was 28 into 3 mm, and MRD1 was -2 and -1. The corneal sensations were also decreased. The deep tendon reflection tone was grossly normal. The ocular movements were restricted in all the gazes. So coming to the ocular ophthalmic examination, this is a patient of a bilateral congenital ptosis with total external ophthalmoplegia with normal fundus. We went ahead with MRI, repeated nerve stimulation tests and EMG studies. There was no decremental response in RNST. The acetylcholine receptor antibodies too were negative. Our differentials in our mind were CPEO, Kern-Sayers and myasthenia. Going ahead, we went with a genetic analysis, and the interesting part here was we found that there was the mitochondrial gene panel was negative, but the TTN gene missense variant was found. The diagnosis of a titin gene-associated bilateral ptosis with ophthalmoplegia born out of a consanguineous marriage with all siblings affected with upper and lower limb weakness was made. And surprisingly, this is the second case which has been reported. The first case was published maybe in 2023. So what was the treatment? We did genetic counseling for the patient. Crutch glasses were offered, keeping in mind that the patient lubricates her eye frequently. Cardiac monitoring was done because titin is also associated with cardiac muscles, and neurology opinion was taken. What is the takeaway? That bilateral ptosis is not always a surgical problem. It's an etiological one. Identifying the underlying cause is the key. In Cherney syndrome, pharmacological therapy works wonders. And in the second case, the symptomatic treatment and genetic counseling was the most important one. Thus, the right diagnosis shapes the right therapy. Thank you.